All right. Well, thank you so much, everyone, for joining today. Thank you for joining our Amethyst at Penn October 2025 seminar. We're proud to offer this content through our Amethyst at Penn Hub, which stands for Achieving Maternal Empowerment and Transforming Health Through Implementation Science and Training. Funding for this hub comes from the NIH's Improve Initiative, which aims to reduce maternal mortality, improve pregnancy, perinatal, and postpartum care. As a reminder, we will be recording this discussion. It will be available on our YouTube channel for review after the session. Please feel free to put any questions in the chat throughout the presentation, and then we'll also have additional time for questions at the end. This month, we're very fortunate to have Dr. LauraEllen Ashcraft here to speak with us about the guide tool for implementation work. Dr. Ashcraft is an implementation science methodologist, an Amethyst co-investigator, and our Amethyst design core lead. So we're very happy to have her with us today. And with that, I will turn it over to you.
Thank you so much, Casey. And I'm so glad every single one of you are joining us for this time. And so let's really get right into it. Today, we're going to be talking about the guide tool and walking you through that. And hopefully this is something that may be useful to you or some of your colleagues. So I want to acknowledge that we all come to this work and to this conversation with different life experiences, different perspectives, and different areas of expertise. And this is something that I value in the work that I do in all aspects of my life, but certainly when it comes to my work as an implementation scientist and an implementation science methodologist, bringing all of these perspectives and lived experiences and areas of expertise together is incredibly important. And so I want to acknowledge and say aloud, make explicit what sometimes we think is implicit, that we want to bring all of these perspectives together to our conversation today. And so to help us have a foundation for where we're going throughout the rest of our talk, I would like to have a shared definition of implementation science. So let's dig into that. So I often describe this idea of implementation science as these two cliff faces, right? We have our current state of what is currently happening in the world around us, and then we have an ideal state. This is where we want to be. This is what we want to see for ourselves, for the people with whom we work, for our communities. And often we have this gap between these things. And for many, many years, we in academia and sometimes in community as well have just decided that this is fine, right? It feels like everything is burning around us. And we just say, this is fine. Well, implementation science says this is not fine. And the goal of implementation science is to really bridge this gap between what is currently happening and what we want to happen in the future. And so, if we want to think about a more scientific definition of implementation science, we can look to the NIH, who describes implementation science as the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings and to improve individual outcomes and benefit population health. So really the goal here of implementation science is to think about what are all the things that we need to do to improve the way that we can close this gap. And so to put it in some more common language, implementation science is the how that we can use to how we help people and communities do the things that we want them to do. And we think about this in many different ways. Some of them we're going to get into today. But the problem is, in implementation science, we often fail to do this, bridge this gap equitably and justly, and we don't do it in a way to help people do the things that we want them to do and that they want to do to really close this gap. And so, with that foundation in mind, I want to think about the many reasons that people come and the many different ways people come to the field of implementation science. So maybe you're a surgeon or a clinician who has an existing line of research that you've been working in a clinical topic area, And through your mentorship that you are receiving, or maybe it's through grant review. I have had this with a couple of my collaborators. They're existing scholars, and then through the grant review process, they are receiving the feedback of, hey, you need to add implementation science to your research portfolio. Maybe you are a clinician. In this example here, maybe you are a nurse practitioner and you say, oh, this is the problem that I am experiencing in my clinical practice. And here's a thing that I want to put into place to help address that problem. But this thing maybe doesn't quite have a lot of evidence. And so you're thinking about, okay, how can I test this intervention that I've identified that addresses this gap, that addresses this social problem? And I want to test the effectiveness of that intervention while also trying to understand what are the factors that impact the implementation of that practice. Or maybe you are a psychologist or some kind of other researcher who is really thinking about this existing research question that you have, and you're thinking about, oh man, okay, maybe are there supplemental ways to add implementation science, but I've already started my study. How do I incorporate implementation science? Now, certainly this is not an exhaustive list, but when I think about all the people that come to me for consultations, the folks that I collaborate with, these tend to be the big buckets that folks fall into. And so, in response to that, myself and Megan Lane Fall, who is one of the MPIs of Amethyst at Penn, came together to develop the guide tool. And guide pulls together and comes from our experiences as implementation scientists, as people who provide consultation and training in the field of implementation science, and also as people who teach implementation science, and pulling all of these things together to think about what is a way that we can provide a tool that people can use to help incorporate implementation science into the work that they're already doing or looking to do into the future. And so I'm going to walk through each of the parts of this of the guide tool and talk about them a bit more, and hopefully they'll be useful to you as well. So I want to recognize that there are a whole bunch of things happening here. The way that we are going to walk through them is from left to right, how we typically think about, and read here in the States. This can be oriented in any way that you want. One of the additional files of the publication of this article has this in a PowerPoint document, and you can reorient these boxes in any way that makes sense to you. Also, we're going to walk through them from left to right, but you should feel free to engage with this and fill in things in whatever order you like. So maybe for you, you already have your outcomes. Maybe for you, you already have your research question that is of interest, or you already have your evidence-based practice. Fill in the things that you already have, and then we can begin to build around that. So yes, we're going to walk through these in a certain sequential way, but you should not feel like you need to adhere to the way that I'm going to walk through them together right now. So let's start with the evidence practice gap. Sometimes we think about this as the problem or the social problem that we are trying to address. And so, really think for yourselves. And these are questions that I use when I'm working with someone who is new to implementation science or who is looking to incorporate implementation science into their scholarship. So, think about, what is the evidence practice gap? Who experiences this gap? Where does it exist? Is this in the inpatient setting? Is this in the outpatient setting? Is this more likely to occur in rural communities or in urban communities? Is this something that high income countries have figured out? But when you get into middle and low income countries, they are experiencing this gap in a way that the high income countries that you work in do not experience the gap. And then, what do the people who are experiencing this gap think about the gap? And this is something that really is working to center lived experiences of the people who are going through, the social problem that is of interest to you. And so really thinking about and reflecting on and asking and listening to hear, what do people who are experiencing this social problem, maybe this is a food desert, maybe this is a lack of access to cardiovascular disease treatment in the outpatient setting, right? What do people think about the gap that they are experiencing? And then how is this gap, how is this problem typically talked about? One of the things that I really encourage my mentees, the trainees, and the folks taking my class is to not just look in the peer-reviewed literature, because the peer-reviewed literature has some really serious limitations. And so thinking about, what are folks on podcasts talking about or social media talking about? How does the news media talk about this problem, if at all? And so really thinking holistically about the sources of knowledge, especially when we think about what the people who are experiencing the gap think about it, and how the problem is typically talked about. So the first thing that we tend to want to encourage people to think about is to really identify, what is the gap, what is the social problem that you are interested in addressing. Next, we think about the evidence-based practice. This, coming from the language of Jeff Curran, is what we call the thing. And if you haven't read that paper, we can put it in the chat. We can provide it as a resource. It's a really helpful way to think simplistically using non-scientific language about implementation science, where admittedly, we really love our jargon. So when we think about our evidence-based practice, this is our intervention that addresses the social problem or the evidence practice gap that we first
Yeah,
identified.
she
And so we want to say, okay, what is our thing? What is our evidence-based practice, our innovation, our practice of interest? And be clear in operationalizing and clearly describing that. So identifying, what is the evidence-based practice? What evidence do we have supporting this practice, supporting this innovation or the solution, right, to our problem? And then thinking about your specific population of interest. And so going back to that first part, right, we're thinking about who is experiencing the problem and where are they experiencing it. And so if we think about low-income folks in rural communities, thinking about where I live in central Pennsylvania, right, and the rural communities, thinking about some of our colleagues who are doing work in the Mississippi Delta, right? What is the evidence for our innovation, for our evidence-based practice or our clinical practice, specifically for that population and for that setting? Oftentimes we think about this from the healthcare or the healthcare setting and the clinical context, whether that be physical or behavioral health. But this can also be true for educational settings, for justice-related settings, right? What is the evidence for this practice within the setting of interest for your topic area? And then thinking about these two boxes that we have, these are the core and adaptable components. These are really, really important. And I could spend a whole lecture really just talking about these two things, but for the sake of time, I'm not going to dig into them too much. But when we think about our core components, these are the aspects of our practice, of our innovation. We use all these terms synonymously, interchangeably. The core components are all the things that have to happen in order for your thing to be considered your thing. And then the adaptable components are aspects of your practice that can be changed. So maybe this can be done in person or via telemedicine. Maybe you find, no, this 100% has to be done in person. That means that is a core component of your intervention. And so the purpose of having these questions, of having this box, is to really think critically about not just what is your problem of interest, but to really thoroughly describe and operationalize what is your evidence-based practice, what is your innovation of interest. Next, we get into implementation determinants. These are one of the things that is so incredibly important within the field of implementation science. We want to identify all of the factors that will have an impact on our ability to put our thing, our evidence-based practice that we talked about on the last slide, into practice. And so these can be challenges for that setting, like for the place where you're wanting to do this or for the population. And then also thinking about the strengths. We want to think about what are the ways that this community of people, that this organization has navigated challenges in the past and will work to that we can use those strengths to overcome challenges in the future. And then really thinking about what do the people with whom you are going to interact to implement this evidence-based practice, thinking about the people who are implementing the practice themselves. We often call this group of folks the implementers. What do implementers think about the evidence-based practice and your ability to implement the evidence-based practice? What do the recipients think about the evidence-based practice? What do high-level leaders and mid-level leaders think about the evidence-based practice itself and also the process by which you are going to implement that evidence-based practice or that innovation? Any determinant framework will help you here. We don't have time today to get into all the wonderful theories, models, and frameworks that we use in the field. I encourage you to go to the manuscript. We listed many citations that will be helpful. I really love the consolidated framework for implementation research, and so I list that here. But when we think about determinant frameworks, we are really thinking about lists of things, lists of factors that impact our ability to put this evidence-based practice into practice. That could be positively impact, it could be negatively impact, it could be either one or both. Next, we want to think about change objectives. Change objectives and this language of change objectives come from the work of Maria Fernandez and colleagues in thinking about implementation mapping. And so when we think about change objectives, we think about them within the context of implementation determinants. And we say, okay, these are the factors, the determinants that are going to impact our ability to put this evidence-based practice into practice. Now, based on that, what are the specific behaviors that we need to do in order to reach our goals, right? In order to get that evidence-based practice into practice. And oftentimes what we encourage folks to do is to really think about these change objectives and map them to determinants so that you can make sure the behaviors that you are going to be promoting in your implementation efforts, in your evaluation or your research project are linked to and cover all of the determinants that you've identified. Next, we think about implementation strategies. Implementation strategies are the stuff that we do to help people, places, communities, organizations, and to do the thing. This is using Jeff Curran's language. And so based on existing knowledge within the field, what are the best ways to help put this innovation into practice? Now, maybe there isn't an implementation research study that's already been done on your evidence-based practice or in your clinical setting or with your top population of interest. That is okay. Really looking for what are some studies that are similar enough to think about how you can do the best job you can at getting that evidence-based practice into practice. What I will say is there are a couple taxonomies for implementation strategies. The most common one that we use here in the US is the Expert Recommendations for Implementing Change, or the ERIC taxonomy. There are also behavior change techniques that come out of the UK by Michie and colleagues related to the behavior change wheel. And so there are different options that you have. You can also work with your community and think with them about, okay, what are the ways that we can get this into practice? Is it about education? Is this about coaching or mentorship or giving feedback about a process? So really thinking about what are the best ways and what are the ways that we want to try to get this evidence-based practice into practice, right? These are our implementation strategies. We then think about mechanisms of change. And now I want to recognize that some of these things do seem very academically driven, and this is for an academic audience. What I will say is many folks have done work in different capacities using similar models to work with community partners. And so if you are working with a non-academic audience, it may be beneficial to help do some education, to talk about mechanisms of change or change objectives or implementation strategies, right? These are not terms that we use in everyday common language. And so I do want to recognize that. When we're thinking about mechanisms, and when you're thinking about mechanisms, how we think about this is what is the process or event by which the implementation strategy or strategies achieve their intended effect. And so the work by Carol Lewis and colleagues provides a really helpful and useful description and examples of how mechanisms of change, sometimes called mechanisms of action, can be operationalized and described. What I will also highlight for folks who are doing implementation science scholarship is that the field related to mechanisms of change is relatively new. There is still some debate about the usefulness of mechanisms of change, and yet it is being included in NIH grant RFAs. And so this is something that is not going away to date. That's really kind of how I feel about it, think about it. And so really to give yourself the best chances of success, it is really important to think about, understand mechanisms of change, and then incorporate those into your scholarship. And finally, certainly last but not least, but thinking about outcomes. So really thinking about the implementation outcomes, your process outcomes, and then your clinical effectiveness outcomes. So some questions that might be helpful to ask. How well does your innovation, your evidence-based practice, get to the people it's designed to support? Does it improve clinical process outcomes? How well is it adopted? Is it being utilized as intended, or are there adaptations that are happening? There are always adaptations that are happening. Thinking about sustainment, how well is your innovation being sustained over time, especially when we, as the researchers, will disappear, right? We will fall into the background. The research funding will not stay around forever. And so when we think about coming into community, coming into spaces and creating these innovations, creating these implementation efforts, it's really important to think about sustainment and sustainability and how these innovations, the evidence-based practices or interventions can be sustained over time, as well as all the implementation support that we're doing. Thinking about the process, how much and how well is utilization going? Thinking about perceptual and behavioral outcomes. So perceptual outcomes, thinking about acceptability, what do people think about the given innovation or or implementation strategies. So acceptability, feasibility, and then behavioral, thinking about, are people actually using it as intended? What does their behavior say around the implementation? And then really thinking about effectiveness, not just from a clinical effectiveness perspective, but also from a implementation effectiveness perspective. There are many resources and ways of thinking and operationalizing implementation outcomes. Some resources I list here include the REAIM framework by Russ Glasgow and colleagues, and then Anola Proctor and colleagues published the implementation outcomes framework that may be of use as well. Then, when we have all of this together and kind of in the process, also as we're doing this, we want to be thinking about the social ecological model and what levels of the social ecological model are being impacted by each of these things. So, if you're not familiar with the social ecological model, these are the concentric circles that we sometimes see with the individual in the middle. Then we think about groups or clinics. Then we think about larger organizations such as hospital or healthcare systems. We think about society. And in some of the work that we've done with some of our Indigenous colleagues, they help us to think about another level, really thinking about Mother Earth and how does the environment impact and interact with our ability to put our given evidence-based practices into practice. And so, really thinking about at each level when it comes to your innovation itself, when it comes to your determinants, your change objectives, your implementation strategies, mechanisms, and outcomes, really thinking about what is happening at the individual level, at the clinician level, at the patient consumer level. What is happening at the group level or the unit level? So, if you're working in intensive care units, you might say some of our implementation strategies are occurring at the unit level. Everyone in the unit is participating. Some of these are policy changes that need to happen across the entirety of the hospital, so more at that organizational level, or across a given healthcare system, as an example. Some of these are community facing perspectives, right? So we want to change community perceptions of a given social problem or of a topic of interest or of an innovation. And so, really thinking about all of these different levels and then identifying that for each of the aspects that you identify throughout the guide tool. And then finally, we come to our research question. Now, as I mentioned at the beginning, your research question, you may already know this, right? This may be the first thing you write, right? My goal is to understand what is the best way to implement a standardized handoff between the operating room and the ICU in different types of intensive care units, right? Maybe that's your research question at the beginning. Maybe you're saying, oh my goodness, you know what? I have all of this data. I've done all of this work over how many years? And wow, I really haven't thought about implementation. Implementation science wasn't even on my radar. Maybe you throw all of the information that you have to the best of your ability into the guide tool. And then, based off of where the gaps that you're seeing in the guide tool, you develop a research question. And so, really thinking about your implementation gap, some helpful questions when it comes to developing an implementation research question. Thinking about your implementation gap, right? That the two cliff faces between what is currently existing and what we want to exist in an ideal world. Really thinking about what are the priorities of the community. Now, when I have said community throughout, oftentimes we think of geographic communities, right? I feel like this term gets used a lot to talk about like urban neighborhoods, right? The urban neighborhoods are our communities. Well, for a lot of our work in the field of implementation science, our communities are the clinicians who are working in the inpatient, hospital unit or working in the outpatient behavioral health center, right? We're doing a lot of work with providers and professionals who are providing support and care to different groups of patients. And then really thinking about what is feasible. One of the things I talk a lot with my trainees, my mentees, is not every study and no study is going to cover everything. You are not going to be testing implementation strategies and testing adaptations and testing mechanisms and testing different clinical settings. You can't do it all in one go. And so, really thinking about what is feasible for the amount of money that I have, for where I am in my own implementation science journey, with what academic resources I have based on my network. So, really thinking clearly about what is feasible for this given project. And so, as I mentioned, there are many different ways you can approach this. This is an example that I pulled together using qualitative data that I collected for preliminary data for my dissertation, so a very long time ago. And what these data are from transcripts, from qualitative interviews with primary care providers across Pennsylvania, thinking about how do they manage chronic pain in primary care settings, and thinking about that, which is what my dissertation research was on. And so, as you can see here, now what I will say is much of this I kind of pulled together afterward. But what you can think about is, okay, what is my gap? My gap is that people who live with chronic pain often are not receiving evidence-based primary chronic pain management in primary care settings. Um, and we don't need to go into all the reasons why that is, but that is the gap that exists. And so when we think about that, we want to think about, okay, what are the ways that we can close that gap, we can get evidence-based chronic pain management in primary care settings. And so maybe we think about, okay, maybe we want to increase access to physical therapy to help manage musculoskeletal pain. Or maybe we want to increase access to cognitive behavioral therapy to manage behavioral symptoms that go along with chronic pain management. Again, we don't need to get into like the topical background of all this. And so maybe we think about, okay, we know, right? We see it at the bottom here. We know that there are a lot of adaptable components. So maybe the physical therapy happens in a physical therapy clinic. Maybe can it happen at home via telemedicine? Could it happen in the primary care clinic? I don't know, right? But okay, maybe it can happen in a bunch of different places. How many sessions are really needed for physical therapy or cognitive behavioral therapy, right? These are things that we have heard, and that I heard from the providers with whom I talked to. But then thinking about, okay, well, what is really required? Well, actually, we're not really sure. So this is really a gap for future work because we don't exactly know what is required in order for people to receive the benefits of these different interventions. We then can think about different determinants that came up through the course of these existing interviews. And so thinking about financial concerns, about copays. That was something that came up a lot. Copays for physical therapy, copays for cognitive behavioral therapy or CBT, right? Thinking about the rurality of the clinic, right? If it's really hard to get places, that can really be a barrier. The availability of people who can provide cognitive behavioral therapy and who are trained to work with people living with chronic pain, right? Thinking all these things. Then thinking about, okay, based on what we know, what are some change objectives? What are the behaviors related to those, right? So then we can think about, okay, we need to identify non-traditional approaches to psychotherapy treatment, right? And this is something, as you can see in the bottom for the social ecological model, right? What things need to happen at the individual level. So, right, individual clinicians who hopefully live in that community can be thinking about all these things. These are things that also need to happen at the clinic level. The clinic needs to provide support about really brainstorming and thinking about how do we get access and improve access in this way. Maybe some of the implementation strategies, and what I will say from this data set is that many of, or I won't say many, some of the PCPs who I talked to had already figured out how to overcome these. And so they said, oh, you know what? I send YouTube videos of physical therapy exercises to people living with chronic pain because they can't afford the copays, or they can't figure out how to physically get to a physical therapy clinic. Or, we developed a group for people living with chronic pain, and we developed a CBT group. We brought in a therapist once a week, and they have a group here at the clinic. People can get to the clinic and they can come here, right? So thinking about those implementation strategies, how are we going to close that gap? And then thinking about outcomes. So these outcomes here used a combination of reaim, right? Thinking about acceptability. To what degree are these interventions, are these implementation strategies acceptable to the different groups of people who are involved, right? And thinking about not just at the individual level, but at the clinic level and at the health system level, as well as at the community level. So this is an example of how you can take work that you have already done. You can also take uh, published like results from the peer-reviewed literature and put it in to this guide tool to help you organize and think about, oh, you know what? No one has looked at mechanisms of change for this topic area. No one has. All right, so that's definitely a gap, right? There's your research question. There's your grant right there, is looking at what are the mechanisms of change as it relates to this example as a topic area. And so then thinking about, okay, we've done all these things. Now we need to design an implementation science evaluation. And so really thinking about what has been used before in this social problem, in this evidence-based practice, or in this setting. What theory, model, or framework are you going to use? And then really thinking clearly about how do we incorporate factors of equity and justice, and really having this be central to our work in thinking about designing our implementation science evaluations and research. I recommend this 2015 Nielsen article that provides such an incredible summary on theories, models, and frameworks in implementation science. It's an oldie but a goodie. We also then want to think about what type of implementation study do we want to do? What, based on the existing knowledge, the existing evidence-based, right? Thinking holistically about evidence, the existing evidence base, what type of implementation study is most applicable? I really like a paper that Megan Lane Fall and colleagues put out in 2019, the implementation subway line paper does a really nice job of helping folks who are newer to the field of implementation science really think about what type of study and study design might make the most sense for me, and thinking about, am I primarily looking at the effectiveness of the intervention? Am I still developing my intervention? Sometimes that's the case. And so if when you're filling out the guide tool, you're like, oh my goodness, I actually don't even know what is included and what's not included in my evidence-based practice, that's okay, right? And so this article does a really lovely job and provides some great resources about how you can incorporate implementation science really across the spectrum of evaluation and of research. And so some other questions that may be helpful to you in thinking about designing your implementation science evaluation, prospective versus retrospective data collection, thinking qualitatively, quantitatively, mixed methods. Most of the time in the field of implementation science, we do mixed methods work. Will there be some kind of hypothesis testing, or is this more descriptive and exploratory? It's okay if there's not hypothesis testing, but really asking yourself these questions. I talked about sustainability before, but really thinking about sustainability in the design phase of a study that you haven't even started yet is just so important, to really make sure that these innovations, that these evidence-based practices, as we're getting them into practice in these settings, are really able to be sustained over the duration. Really, I'm thinking about how your innovation, your strategies, or the context may need to be adapted in order to successfully do this given intervention or evaluation or implementation. And then really thinking about how are you going to engage your community and clinical partners throughout the study, the implementation process, etc. I recommend Frame and FrameIS as being some helpful ways to think about and track adaptations throughout your implementation process, and even before your implementation trial begins. One of the other things I want to highlight briefly before we wrap up is that we have used Guide as a way to help orient teaching and implementation science. And so if you are someone who teaches a Foundations of Implementation Science course, or maybe is thinking about doing some workshops in implementation science, we really wanted to share how we orient these. And so this is a screenshot from the class that Megan and I taught last fall, in fall of 2024. And the class that this is actually the version for the class I'm teaching this semester in fall of 2025. And so thinking about hitting on these different really important components of implementation science throughout the course of the semester, you will note that we get through most of this in the first, I would say, 2/3 of the semester. And then the last portion of the semester, we talk about other topics such as dissemination approaches and some other topics there. And so here are some learning objectives from our course. Truly, I copied and pasted these off of the syllabus to put in the table here. So really thinking about providing this high-level overview, discuss competencies in implementation science, really think about the standards of evidence. So evidentiary standards are different based on the definitions or the field and disciplines that you're in. Thinking about determinants from the behavior change wheel perspective or COM-B, we do some work in using CFIR, and so looking at the CFIR domains. And it seems like my slide deck has a mind of its own. And then thinking about change objectives, right? We spend some time really thinking about change objectives, implementation strategies, and mechanisms kind of simultaneously. And so really making sure that we're clear in saying these are our determinants, yes, but then this is really how we want to operationalize these things, put them in terms of behavior, and then really identify what are the ways that we think this effect is having its effect. And then thinking about our outcomes, right, in the same way that we talked about before. So this comes to the end of my presentation. The published paper came out last week or a week and a half ago, as you can see. And so please feel free to take a look. I'm more than happy to answer any questions that you have about the guide tool, about how we think about this. And thank you so much for being here.
Thank you so much, LauraEllen. That was wonderful. And congratulations on the publication. Very exciting. Do we have any questions? Feel free to come off mute. Feel free to put them in the chat. I can read them out. Go ahead, Cheryl.
Hi, thanks so much for that presentation. My name is Cheryl Bamus. I'm a professor and direct our maternal and child health program at the University of South Florida College of Public Health. I was wondering if you could provide an example or a little bit more description about the necessity, and you mentioned proposals or willingness, the change mechanism. So if we have the intervention strategy, how does the mechanism differ than the strategy? Is it just like explaining like how the strategy works? And if I don't know if there's an example you might be able to share.
Yes.
Yeah.
And this may be something that we can go, if you want to find a time to meet, we can go into a bit more detail here. I think really this is where thinking about what is the thing, what is the thing by which your strategy is having its effect. So is the coaching really about self-efficacy of the clinician? And so then, right, like then self-efficacy. And so for folks who have done causal inference work, right, maybe some of us want to try and forget, our causal inference classes during our master's or PhD programs, but really thinking about DAGs, essentially what it is trying to do is then to create these causal pathways in the field of implementation science. And so what I will say is that mechanisms are still relatively new. And mechanisms of action, mechanisms of change, depending who you're reading, they're used interchangeably. But that's really the thing that it's driving into is by what pathway is your implementation strategy having its effect? And so then the hypothesis is that Well, if you know the pathway, maybe it's more about the pathway than it is about the strategy. And so if it's something about self-efficacy of clinicians or knowledge and awareness of clinicians, for example, that is the mechanism that's really driving that behavior change that is closing that evidence practice gap. If that's what it's about, then maybe your menu of options of implementation strategies are any implementation strategy that increases self-efficacy. And so maybe that's coaching, maybe that's audit and feedback, or maybe it's facilitation, or whatever other strategy. But if you have additional questions, I'm more than happy to find a time and we can talk more about that.
Thank you. That example was super helpful.
Yes, I think there's another question. Abele? Did I say that
Yeah,
right?
yeah, you said it right. Thank you. Thank you for your presentation. I really enjoyed it. So I understand that innovation is relatively important in implementation science. So, and cannot be overemphasized. So I understand that perfectly. And don't get me wrong. But I have a quick question. So from your knowledge and from your presentation and your knowledge in implementation science, do you think it's okay to build on evidence-based research study that, in quotes, is effective without being innovative?
Yes, this is you have raised such a good point. So thank you so much for this question. The way that we think about innovation, this is where I get to put on, like, I guess I already have my nerdy glasses on, right? But this is where I get to put my extra nerdy hat on. This comes from diffusion of innovations theory. And the way that Rogers defines innovation from diffusion of innovations theory is that an innovation is anything that is new or is perceived as new to that given setting or context. And so just like you've said, right, if we have an effective practice that exists in one mental health clinic, but another mental health clinic has that exact same problem but has not used that evidence-based practice, it would be an innovation for that second outpatient mental health clinic because it is a new thing for that clinic. Is that making sense? So it's not, it's more as using innovation as a noun and not an adjective, if that makes sense.
So I get that. Now, a follow-up question. In the course of your study, have you ever experienced a barrier where a situation where culture becomes a barrier for you to implement maybe an innovative evidence-based study?
Yes, all the time, actually. So I mean, culture can mean many things, right? It could be like um, culture of a particular subgroup. I will give an example. Some clinicians that I work with are surgeons, and surgeons have a very, this is really leaning into stereotypes here. It does tend to be true in some ways, but surgeons have a very particular way that they think about the work that they do when they and how they like to receive feedback. So I'll give an example of one of the studies that we did in the VA looking to provide age-friendly outpatient care for older veterans, so veterans over the age of 65. And so one of our interventions was working alongside surgeons to help have goals of care conversations before they did outpatient surgeries with older veterans to make sure that if the veteran was deemed to be too frail, right, that they would have this goals of care conversation. So that's the one intervention. Another intervention was providing caregiver support for caregivers of older veterans with dementia. And so, there's lots of literature around burnout and things for that group of caregivers. And so we wanted to provide them support as well. The implementation strategies that we had planned to use were an audit and feedback tool. So saying, this is the thing we want you to do. We want you to be using these interventions. And the strategy we're going to use is we're going to look at how well you're doing that over a period of time. And we're going to send you a report and let you know how well you did. So for the surgeons, that worked really well because it aligned with their cultural expectations and the culture of surgery and how surgeons tend to receive feedback anyway, right? They tend to receive lots of matrices and see how they compare with other surgeons regarding certain outcomes. When we did that same format for the occupational therapists and the nurses who were doing that home-based primary care intervention, providing care for or support for caregivers of older veterans with dementia, they did not respond well to that at all. They were like, nope, this is not my thing. I don't tell me this doesn't align with how we in occupational therapy, how we in physical therapy and outpatient nursing think about these things. We don't think about them in terms of numbers. We think about them in terms of people and how well we're interacting. So when it comes to culture, this is something that is called out in the updated CFR. And so there's some really helpful definitions in thinking about staff culture and priorities of how recipient-centered is the place where you are looking to implement your innovation. So hopefully, if I didn't answer your question, please, we have time. We can ask another one. Yes. Oh,
Thank you so much.
yeah, you're welcome. Mary.
Hi, and thank you for this wonderful presentation. This is probably just Mary Shaw just trying to understand if I have been trained in intervention mapping and I want to contextualize implementation science with intervention mapping, is it safe to say that the implementation science is the broader umbrella under which intervention mapping occurs, or is it the other way around? Because that's what I learned, but now I'm trying to make these two come together. And I know there's some missing pieces. And when you introduced this mechanism of change today, it had me thinking, are we talking about the first thought that came to mind was Prochaska's stage of change, having to know how the change will occur. If it's some physician behavior, but how the change will occur and trying to figure out where do I go to look at that. Okay. So the first part of the question is intervention mapping relative to implementation science. And then the second one has to do with mechanisms of change within either one of those two frameworks.
Yes. Great question. The way that first of all, I'll say this, this is kind of my perspective. I think if you got a bunch of implementation scientists in the room, we'd probably have a debate and go at it, and it would be intellectually fun and probably not super practically useful. But so with that caveat in mind, I tend to think about implementation mapping and which is one of the key things that we relied on to develop the guide tool. But I tend to think of it as step 5 of
Okay.
the intervention mapping
Okay.
6-step plan, right? So it's the implementation plan. So it's thinking about, okay, you've done your intervention needs assessment.
Mm-hmm.
You've done your formalization of your intervention change, right? It's like very focused on your thing, on your
Mm-hmm.
intervention. We are then building all this out for step 5 to think about, okay, how do you get that intervention into practice?
Okay.
And so that's how I tend to think about it. And then your question regarding mechanisms of change and mechanisms of action, where does that fit in? So as I mentioned, the conversation around mechanisms of action, mechanisms of change is relatively recent, I would say in the last 5 to 7 years. And so we are still, my interpretation is that we are still as a field trying to figure out exactly where it fits in with kind
Mm-hmm.
of the rest of implementation science. And so I think, again, my interpretation and kind of what I am interested to see is really the first big wave of the mechanisms of action trials that happened.
Okay.
We're waiting for the results papers to come out to kind of
Okay.
see how does it really fit in? And so I think mechanisms can be really helpful. if done correctly. I think if kind of done incorrectly, it feels a bit like another academic exercise that maybe doesn't impact our communities as much, and the folks who are experiencing these gaps as much as I think we would like.
Okay. So last observation, I think the takeaway point for me on mechanisms of change without having read that literature is simply you have to be mindful that there is a process by which the change will occur, even if it's a strategy that you want to use. You may not know what that is, but you certainly got to give some consideration to it. Okay.
Yes, I think, thank you, Dr. Shaw. You have summarized it so well. But yes, that's exactly right. We can be aware of it. Most of us, because of how big our sample sizes are, because of, again, that feasibility question, our trials are not big enough to systematically and empirically test mechanisms of action, but we can, to your point, be aware of them and conscious of them and report what we think they may be, even though we aren't able to fully test them empirically, perhaps in a way we would like to in some kind of ideal fantasy world.